Good afternoon and good morning to you. You are on the West Coast. My name is Dr. Jose Leon, Clinical Quality Manager for the National Center for Healthy Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, What is Health Data Telling You? Using electronic HIE data for public health and health promotion interventions. This webinar is being recorded and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. I would like to remind all attendees to complete the post survey. Your feedback helps us improve our webinars. I also would like to thank HIRSA for allowing us to make this webinar possible. And all this information is possible because of HIRSA, so we would like to thank HIRSA. And I'd like to get started and introduce our speakers today. The very first speaker is Andrea Bankowski. She is the Virtual Data Unit Manager at the Maryland Department of Health and Mental Hygiene.
No, you asked me for your slides. So I can...
The Virtual Data Unit Central Hub for State Health Data produces data for public health surveillance, refines data methodologies and standards, and facilitates data work groups around best practices, software, tools, and techniques. Prior to join Maryland Department of Health and Mental Hygiene in 2010, Ms. Bankowski held public health and clinical research positions with Harvard Medical School, the National Institute of Health, Institute of Medicine, and the Virginia Department of Health. Our next speaker is Scott Afzal. He is a partner at Audacious Inquiry, a health information policy and technology company. Scott also serves as the program director of Maryland's statewide health information exchange called CRISP. His responsibilities include managing the rollout of CRISP's HIE network and leading the development of new service offerings. He has also managed the implementation of large-scale master data management platforms focused on patient and provider identity management. Scott is a noted speaker on health information exchange, having presented at regional and national health IT conferences. Prior to joining Audacious Inquiry, he served as a business and systems integration consultant with Accenture Inc. And Scott holds a BSBA in business management from Bucknell University. And our third speaker is Zara Marsalian. She is the CEO and co-founder of La Maestra Community Health Centers and La Maestra Foundation. She co-founded La Maestra to provide healthcare and social services to help the underserved, low-income, homeless, and immigrant refugee residents in her inner-city San Diego community to become healthy and self-sufficient. Since 1990, La Maestra has expanded to serve 45,000 patients annually in several areas of San Diego, including City Heights, El Cajon, National City, and Lemon Grove. Zara has been actively involved in community organizations and other nonprofits for over 25 years. She's been recognized locally and nationally as an ambitious advocate for the cause of helping the underserved and improving access to culturally competent health and health social services for the diverse communities of San Diego. Recognition includes the Community Health Leaders Award from the Robert Wood Johnson Foundation and the Green Lining Institute Lifetime Achievement Award. This is data taken from UDS, and the 2014 data shows that 96% of health centers have EHR installed. 88% of them have EHR available for all providers at all sites, and 85% of these HIRSA grantees use an EHR to report clinical UDS data. The Health Information Exchange allows healthcare providers and patients to access and securely share a patient's vital medical information and improve the speed, quality, safety, and cost of patient care. The adoption and use of health information exchange in underserved settings appears to be impeded by regional, inter-organizational, and intra-organizational factors, and facilitated by perceived benefits largely at the intra-organizational level. Some of the benefits are avoid readmissions, avoid medication errors, improve diagnosis, and decrease duplicate testing. Without further ado, I would like to turn the presentation over our first presenter, Andrea.
Hey guys, hold on, I'm just going to get my screen set up here so you can see my slides. So I hope everyone's having a wonderful Monday here. And so actually, Scott and I are presenting together. So what I'm going to do is talk about our work with his data from CRISP. And how basically we use the CRISP HIE for our public health analytics. So just to give you a quick background first, I wanted to talk a little bit about the Maryland Department of Health and Mental Hygiene's Virtual Data Unit. So just a background about that. So basically we launched a Virtual Data Unit a couple years ago in 2012. And some people are wondering, well, what is a Virtual Data Unit? It's a central virtual hub for all of our health data. So it's not a physical data warehouse. We already have the data falling under different administrations. They already have them set up under their servers. So it'd be really expensive to try to put it all together. So instead we thought, well, why don't we make this virtual hub so we know where the data's at, who has what data in which administration. And so I'm kind of like the point person. If somebody's looking for data, they can contact me. We do have over about 100 members within the department as well as external members. And so we get together for quarterly meetings and talk about the data, talk about linkages or other projects we could do with the data. And so this is just a slide of all the different administrations at the Department of Health here. And we're tied into all these different administrations and their data. So the mission of the Virtual Data Unit is to facilitate data access. Oftentimes, previous to the Virtual Data Unit, they didn't know exactly who might have the exact data that somebody might be looking for. And there were kind of some silos around the different administrations and data itself. So this is put in place to help break down those silos. And also understanding how everyone's using their data, getting people to talk to each other, breaking down those communications, and just finding out about different projects. Somebody might be doing something similar with their data as somebody else is doing, and it might be a good idea to try to link the data together in some way or collaborate. Another thing is just talking about data policies and standards. Each database has their own sort of rules or guidelines, whether it's a CDC grant-funded survey or whatnot. So, it's hard to make one overall policy or standards for every data set at DHMH, but we have a guide so that people can look at the summaries and understand what data has cell suppression rules and usage recommendations for each type of data set. And another thing the Virtual Data Unit is really big on is improving the data methodologies within the department. So, different things like how to age adjust. Let's all do it the same way because there's different methods for age adjusting, best practices for analysis of the data, how to check for data reliability and other more statistical practices that we can help people with to make sure that they're presenting and putting out the best data possible. And whenever there's a change with data, just communicating it to everybody that uses that data internally and as well as externally. So just basically that's just a slide here of all of our different types of data in the health department. And, all of this data helps us answer a lot of general and specific surveillance questions about Marylanders. Sometimes, though, we need to go outside of DHMH in order to answer some surveillance questions or dig deeper into the questions we're asking, because maybe our data leads to more questions. And so that's where CRISP comes in. CRISP is a Maryland statewide HIE, and it stands for the Chesapeake Regional Information System for our patients. So an example of putting this HIE data to use will be, I'm going to be talking about how we used it for the overdoses in Maryland. So we have a major overdose problem in Maryland, and this is something that also follows national trends. This is an issue nationally. It's all over the news, and several states are having a problem with it, and overall in the United States. So in Maryland, we have really great data to track overdoses. We've been doing that for a couple years. We get a monthly data pool from the Office of the Chief Medical Examiner, and then we also supplement some of that with the vital statistics death certificates to create this data repository. So on top of this is the death data. On top of that, we also have hospitalizations and emergency department visits that we track. So anything looking at non-fatal overdoses and trying to track that as a measure. And that includes, that database includes every single hospital in Maryland. So I think that's a kind of unique in the sense that we have every hospital tied into this database. So it's not real time. It's about on a monthly lag, and we analyze the data annually or quarterly. And so this is really high quality data where we're able to look at identifiers in that data set. It has place of occurrence, so where that death occurred, what county or zip code, as well as the address level, which we might want to create a point map or something like that of looking at that. And it also has place of residence, so where that decedent lived, which Maryland county they lived in, the date of death, their type of drug that was in their system. And the only reason that we have that, and we know it's good quality, is because that's from the OCME, the Office of the Chief Medical Examiner's tox reports. So we're able to run an algorithm that we developed in order to identify the types of drugs in that person's system. And then additionally, we have demographics in that database. So race, ethnicity, gender, age. And this database, for the deaths and for the hospitalizations and emergency department visits, answers the descriptive epidemiology questions about person, place, or time, also known as who, what, where, when, and how many. So we get a lot of great surveillance data in order to inform our intervention programs and outreach. So one example of a statistic for the surveillance data would be that in 2013, there were 858 individuals that died of an overdose in Maryland. So this is helpful to know, and it's also helpful to track that number over time. And it is increasing at an incredible rate, actually, since 2011 was sort of the base point, and then it started jumping up from that point. But we were thinking, what else? What could we answer to dig deeper into the data with this type of statistic? So when you get data like this, surveillance data, this answer or knowing the general surveillance often leads to more questions. So you have another sort of question that comes up. How could these 858 deaths have been prevented? And that filters down into a more specific question of how can we identify individuals at risk and get them into treatment. And so that leads us to our kind of research or surveillance question, more specific surveillance question of, did other overdoses occur in these 858 individuals previous to their death? in thinking that, okay, if there's some way we can capture these people before they're passing, then and get them into treatment, then we need to pursue that public health intervention route. So that's where the CRISP data, the HIE, comes into play. So in a retrospective analysis, we basically took that question: did other overdoses occur previous to their death? And we were able to give CRISP the 858 individuals. We gave them identifiers of those individuals in order for us to do, for them to kind of match them up into their system. And so the CRISP HIE contains every hospital in Maryland, and it is real time. Basically what they're able to do with that data is go back and match those records and look at their hospital utilization trends up to 12 months prior to the death. And we wanted to answer the question of how many of these individuals had a visit for overdose, and how many of those visits were readmissions. Like I said, the CRISP data is every single hospitalization and emergency department discharge in Maryland. We have a hospital database. That's the one I was talking about earlier, where we do our general surveillance trends. However, that database that the state owns does not have identifiers. And like I said, it's not real time. It's only quarterly. So what CRISP has done is basically they connected to every hospital and emergency department visit, and then they were able to create this master patient index. And they do collect name and other identifiers. And so with that master patient index, they connected to our state hospital and emergency department visit database, and in merging that together, we're able to have that identifier. And additionally, so we can also look at readmissions, because our current state data set, we cannot look at readmissions since there is no identifier. There's no way to track if that is the same person coming back. So their HIE is a wealth of information for us. Readmissions are a huge, huge problem, major healthcare costs, and things that we need to be focusing on is following those trends. And so now we're able to do it with the CRISP system. So in kind of like a pre-query of this analysis, you know, the virtual data unit wants to make sure they're kind of following the best standards for data. So before we even started the project, we had been talking to CRISP about their data and getting familiar with what they have and what kind of data that could be helpful to inform us as a public health department. And so the first thing we want to know is what's the quality of the data and what are the limitations. And so way back several years ago when we first started meeting with them, you know, we were looking at the validity, how accurate is this master patient index? Is it capturing, you know, every single visit? And so our state system is required, the hospitals are required to report every single visit. And so that's sort of like, we know how many visits there are. We don't know how many patients, because like I said, we can't identify, there's no identifiers, but we know how many visits are going on in the state of Maryland. So we were able to, CRISP is able to validate the quality of their data by assessing if they can capture every single visit. So they're literally like a 99.9, if not 100% valid of capturing every single visit with their, and linking that data to their master patient index. So we knew that it was high quality. There's no limitations of underreporting. Then the next step is just setting up a memorandum of understanding and a data use agreement for on their end and our end. You know, we're transferring them our death data there, and then they're doing a check and sending it back to us with the aggregated data. So just you know, hashing that out, the details of why we need the data, how we use it, what they can and can't do with our death data, and so on. So you know, we hash that out, and then this MOU applies to any future work that we do with them. Then looking at the methodology, so there's a certain way that we pull out an overdose visit with the ICD discharge diagnosis codes. International Classification of Diseases is the ICD. And so we at the state took several months to develop a methodology. It actually, in general, there's no national standards for what defines an overdose. Like there is for asthma, there is for diabetes, there are for several other conditions, but for overdoses there's no standard. And so we're kind of looking at what some other states were exploring, and then based on that and then our own looking into developing a methodology, we came up with all the codes we wanted to do to identify drugs of abuse, as well as excluding certain cases. So we excluded anything that was attempted suicide or attempted homicide from those diagnoses, because that's another factor coming into play. And so then we share that methodology with CRIS so that they can pull out the data exactly how we wanted it to be pulled out. And then having a clear, specific data question. And I covered that in how we sort of filtered down into a very specific question. With any HIE, and if any of you guys are thinking of trying to get data from an HIE and requesting a data pool for something, it's really important to just try to come up with a specific question. A lot of times people think that it's a good idea in general, that they want a general type of data. And maybe they even know different ways they want it stratified or in demographics, but it's good to actually have a specific question that data is going to answer. Because in the end, if you just ask for random data and don't have a specific question you have identified, you're probably going to have to go back to that HIE and have them re-pull the data, because there's so many different ways they can pull it out. So going back again, so they linked our death records for those 858 individuals that died in 2013 of an overdose to their CRISP records in order to determine how many of those had any kind of visit in the hospital or emergency room within the previous 12 months to their death. And this is the data that we received from them. So this is showing the number of visits for each of those 858 patients. So, for example, the first bar, visit 1, 230 of those patients that died of an overdose had at least one visit in the 12 months prior to their death. So that's a pretty high number out of the total amount. Individuals in total with one or more visit was 502, so close to 60%. And as you can see, like at the end there, you have people that are having multiple readmissions. So 7 visits, 11 patients had 7 visits, 8 or 9 visits was 12 patients, and there were even people coming in 10 times or more, 26 individuals. So that's within 1 year time frame that was 10 or more times that somebody could have pulled them into a treatment program directly from the hospital. So, and then if you also think of the cost associated with all those visits that could have been prevented had we gotten them into treatment in some way. So the total number of overdose visits was about 1,500, just over 1,500 for those 858 individuals. So what we basically wanted to do this assessment for was then to figure out if this was the right route in order to take some kind of public health action with this HIE data and get the hospitals on board and the local health departments on board to getting these patients into some kind of addictions treatment service. And so basically we created we worked with the local health departments to establish a voluntary reporting protocol for all non-fatal overdoses. And so these individuals would be referred to treatment, have some education and resources on overdose prevention provided to them. And the idea was this year to start piloting this with several hospitals. And again, this is voluntary. So then basically taking that data, and I think they're in the review period coming up soon to figure out how that pilot's working. So, so this, in a way, that way you can have somebody in the hospital enable in that moment when somebody is at the hospital for an overdose to then touch on them then and get them into treatment from that point. So basically some takeaway just working with the analytics side of the HIEs is, again, I just wanted to stress the importance of data quality and finding out what your HIE in your state might be able to offer you. I know that some HIEs don't have every single hospital connected to them. However, I wouldn't discourage the use of that data. I would just say, know that limitation, and then maybe you could even do some kind of statistical assessment of, if it's only 60% of the visits in your state, then you can do some kind of estimate of projections of how that data would sort of apply if it was applying to everybody in every hospital in the state. Then the other thing is about big, a lot of people throw the term big data. I'm not really a fan of that term. Big data doesn't necessarily equal valid data. So, again, I'd rather people use the term big valid data. Just keeping that in mind when you have access to any type of data repository is knowing how valid it is before you do anything with it, because you just don't know how good it is. And then setting up your MOUs and DUAs with the HIE to get something where you can maybe get some kind of ongoing feeds from them or whatnot, just to hash those details out at the beginning. And then as long as the requests don't change significantly, you don't have to go back to that. And having some kind of analyst, epidemiologist involved in the request, if you yourself aren't familiar with that, so that they can help you prepare a methodology and understand exactly what kind of data you want to get from the HIE. And then once you get that data, they can help you analyze it according to standard recommendations for creating rates or age adjusting or different types of analyses depending on what you're doing. And additionally, I think interpreting the data, because depending on, especially with maps, if you're putting something on a map, it can be very easily misinterpreted. So kind of helping you hash out that information to get you to the best clear answer that you need from that data. And again, knowing the data question before you request any data. So one of the sort of, I wouldn't call it lessons learned, because this with CRISP was very smooth and we're on both of our ends, but I definitely recommend that you, the HIE might want to consider standardizing their process of requesting data. If they're new and they haven't yet started getting data requests in, so it just becomes easier for them to have a standardized process. And then again, like making sure the requesters have a clear idea of the question in mind to eliminate the time wasted on them having to rerun the data. So, and then this is going to get into, the next slides are going to get into the CRISP data system, the CRISP HIE, and is Scott on the line yet?
Not yet.
Okay, so so Scott is from the CRISP HIE, and he was going to kind of go through these slides to give you more technical information about that HIE, but I'll be able to kind of cover these slides in general since he's not on the line yet. So basically, they had a challenge when they got started of the hospital systems feed into the statewide feed doesn't have any unique patient ID. Like I had said earlier, there is a medical record number. However, that medical record number is only for each specific hospital. So, for example, if somebody has the same number at one hospital and another hospital, that's not the same person. It's just, so they don't crosswalk between the hospitals. It's only within the hospital. So you could, in theory, you could create readmission rates within a hospital. However, from a public health surveillance standpoint, we don't usually do analyses at the hospital level. Normally, we're doing it by county or statewide in order to see like where the hot spots are of residents that have visits. So basically, they, like I said, they were able to create this master patient index. They got on board with all the hospitals, and the hospitals were giving them a feed of like name, address, and some other birthday and some other demographic information. And that system is utilized by CRISP in order to inform physicians that are signed up with CRISP of their patients if they're having a hospitalization or emergency department visit. So if I'm a doctor and I sign up to be in the CRISP system, they will have a list. They'll know who all my patients are. And anytime one of my patients goes to the hospital, I'll get an email alert that very day. And in that way I can follow up with them and say, you know, hey, Joe, you know, what's going on? I think we should come in for a primary care visit to, you know, manage your condition if you're going to the emergency room because, you know, you have diabetes and this is something that should be managed in the primary care visit. If it's not being managed there, then we've got a problem. So, anyways, with this demographic, with these identifying variables, they were able to connect and link to our data set. And one other thing I forgot to mention that we don't have, that they do have, is address level data. We only have zip code, down to zip code. So that's another factor where we could do, with the CRISP data and them having the address of the patient, we can get more detailed to looking at hot spotting in certain areas at a lower granularity. So I'm not going to go into this slide. It's a little too technical. Basically, just showing their data flow here, though, through the hospitals feeding into the master patient index is the top box there, and then they are assigned the unique ID, and then down just below that is the HSCRC. That's our state hospital data, and so and then that abstract data gets put together, those things are merged together, and then you're able to do a lot more with it. So alone, you know, you can't get as clear of a picture as you can with the data sets merged together. And there are other tools that they use, like if you guys are familiar with Tableau, it's a data tool where you can put in a feed of the raw data and then have people on the other end look at that data in aggregate form, maps or stratifications and trends, and kind of almost, it's more of a tool for maybe a non-data person to look at the data and explore it and create their own little tables and graphs. So then this is just a slide about the population health utility aspects of CRISP. So I mentioned the example of the physicians getting a alert, you know, less than 24, 48 hours from when their patient goes to the hospital. There's a lot of other things you could be doing with it. A lot of people in the state of Maryland from hospitals themselves are using this data. Providers, like I said, the DHMH, our state health department, and then researchers, pharmacies, just list goes on for the use of it. And this is an example of, I mentioned Tableau. So this is an example of what a table you could create in Tableau. So, you know, CRISP, at some point, I think we're working with them to create some public health portals. And right now we're just creating portals for internal use but eventually, you know, we're sort of beta testing some things, and then eventually I think we'll make some type of lead towards a public portal, so anybody in the state of Maryland can get into this portal and look at these general data trends. And they're more interactive than a lot of the data that we do at the state. So this is an example of just looking at the hospital use trends by county. It has the number of inpatient discharges, then the charges associated with those visits, readmission numbers and rates, and then the readmission costs, as well as emergency department visits and charges. And then you can kind of set up Tableau in different ways. You can show it on a map, you can show graphs, and play around. So right now we're just kind of having fun playing around with the how we want the portal to be viewed and what types of data we think are the most informative for us as a health department, and also for the public that would want to utilize this data to reduce healthcare conditions and costs in the state. So that's pretty much it. Thank you.
Thank you, Andrea, for this great presentation. And our next speaker is Zara Marcelian. Good afternoon, Zara.
Good afternoon. That was really interesting, Andrea, and I had a couple questions for you. Do you want us to wait for the questions afterwards, Dr. Leon?
Yes, Zara. We should do the Q&A just after your presentation.
Excellent. Okay. Well, I just wanted to start off with a few slides I'll run really quickly through just to give you a background. La Maestra is an FQHC, a federally qualified health center. We first opened in 1990, and there you can see a picture of us in 2010. We finally were able to open to build and move into our LEED Gold certified health center, 36,000 square feet. Super, tech on, just like very up to date on all of our systems, including EHR and other pilots, including the HIE, which we will get to in a minute. So we serve a lot of patients. We started off as a nonprofit educational organization, and those 12,000 students, part of the Amnesty program, identified that they needed culturally diverse health care in their neighborhoods and in their communities, and that's how we started, was with those 12,000 students, and then the clinic became its own 501c3. Now we have 5 medical and 8 dental centers throughout San Diego County, serving over 45,000 patient visits. We are designated as a 330 I, which is a public health and housing designation through HRSA, as well as a homeless designation and a general population designation, which just acknowledges that the health center sees predominantly uninsured and underserved populations. We have a mobile clinic that offers medical, dental, optometry, telehealth. We're in 4 schools where we offer medical and dental. We were the first FQHC in the state of California to start our own imaging unit, and it offers mammography, X-ray, ultrasound, DEXA, and this year we're adding CT scan, and it's all through digital software. It's really cool because talk about exchanging information with the hospitals. Before we send down the patient to the hospital, we can electronically transmit those scans to the into the surgeons there, and the patients then don't have to go through waiting for scans and interpretation of, and then the hospital having to figure out what the issues are. This way, when we send down the patient, if they've been scanned with us, the hospital's ready for them, and they already have diagnosed what the issues are. So diagnosed. Now, these are the annual number of patients and visits. You can see, where are we now? 14, okay, total visits, about 218,000. Again, majority of our patients indicate that they would rather be served in another language besides English. Okay, next. And so we developed different models to address those needs that really make a difference in how we deliver the system of care and how the message is crafted for whatever it is that we're doing, whether it's health education or basically figuring out what kind of treatment to offer these culturally diverse patients. It's not that the treatment varies, it's how the explanation and how it's presented and who we use. We use these culturally trained liaisons, and these same folks have been all trained on our EHR and our patient-centered medical home model. We're part of meaningful use, which we'll get to in a minute, which leads into HIE. So you can see from all the different countries. Over the years, since 1986 until now, we've created a circle of care. As I said, we didn't start off as a health center, but we started off teaching many survival services or English, second language, vocational training. We had preschool and so forth. So through that, we then were able to add on the clinic, which is all in red, the services there. And at the same time, keep going with our job training, economic development, housing. We do transitional housing. And then you see the darker blue, legal advocacy services. We've kept that through from the amnesty days, and we've added on to it to work with human traffic victims and victims of violent crime. Lots of different needs. Seems like everybody needs legal services. And then we have the complementary services, for nutrition, obesity prevention, health education, translation, transportation, lots of cool stuff. We've got a community garden. Go ahead. The HIE actually started in San Diego County here in 2010, and UC San Diego received this $15.3 million Beacon Cooperative Agreement, and so San Diego was one of the 17 communities to pilot this, and I remember going to the first meetings, and it just was incredible. Everybody was waiting at the meeting. All the hospitals were there, and of course the clinics and managed care plans, and everybody thought, well, gee, for us to proceed, I guess we'll have to wait till the hospitals all get on to the same, EHR, which of course was impossible. So, but we all knew that the goal was to strengthen the health IT infrastructure and achieve strategic goals that we all are focused on around patient care, being efficient, and of course offering higher quality, more seamless delivery of care for the patients, and then be able to realize population health improvements. The UC San Diego Beacon partners, is the Council of Community Clinics, LEMICE as a member, and all of the other health centers in San Diego County and surrounding counties, so those very rural areas as well. Additionally, County of San Diego, Hospital Association, Medical Association, and San Diego Fire and Rescue Department. And basically integrating health IT into care delivery, the important point here was to, yes, measure and evaluate the targets and of course baseline data, establish that, and be able to demonstrate that we as a county have pulled together and through the exchange of information are now delivering better care than we were before. But that all depended on the details of how this information was going to be exchanged. Okay. So one of the targets was quality for the cardiovascular and cerebrovascular disease. And this is just an example here. And with the chronic disease care, we wanted to reduce 30-day readmissions through this improved discharge planning. And then another one is another clinical target through Beacon was population health, the immunization rates, and basically monitoring these syndromes that were resulting from immunizations and so forth. Cost efficiency, we wanted, again, to look at those emergency department visits and how and try to figure out how we could reduce those unnecessary visits to the emergency room that could have been dealt with at a primary care level at much less cost, and then how to reduce those hospital admissions and reduce repetitive imaging tests every time some patient presents at a different hospital with, abdominal pain, for example, and it's there was no record countywide on these patients, then the hospital obviously would have to follow protocol and begin labs and imaging and so forth at a great cost to the taxpayer. Goals for health centers, ambulatory providers, primary care, was to increase access to inpatient discharge summaries via web portal. And that was really important for our providers to be able to have that information, discharge notes pop right into our EHR system. La Maestra uses next-gen EHR, as well as many of the health centers in the state of California. Let's see, connect providers, yes, obviously to all connect all the providers in San Diego County to this immunization registry that actually did exist previously through the county, and but it really wasn't like sharing information. It was more of a repository of data where the county could then issue reports retrospectively. It wasn't something that we could, let's say somebody showed up at our health center, we could, get onto the system, the registry, and see where it is that these patients that were accessing care with us today for immunizations, where they had already been and what immunizations they had received. It wasn't that real time. So it was great to see this whole effort move over as a goal under the Beacon HIE project. Again, we wanted to connect the providers to the County of San Diego Department of Public Health for reporting purposes. San Diego County, I should point out, is one of the few counties in the state of California that does not have its own hospital. So the only hospitals that are here are privately owned. Yeah, so there's no place for uninsured patients or indigent, homeless patients to access care, let's say, at a county-wide level, unless they are being referred for contagious diseases, like TB, tracking. The rest of the care is done through the safety net, which are the health centers and emergency rooms. So San Diego, yeah, in 2013, they really started getting active, and they changed the name from Beacon to San Diego Health Connect. Again, it seemed like, every so often with the learning curve and finding out, I guess through consultants and also through these meetings, everybody came to consensus that we kind of needed to change the focus a little bit, expand members into what was Beacon before, which was a pilot, now became the San Diego Health Connect and was much more inclusive, which was great. So you can kind of see the list of the partners there. And it said better information for better care, which we all hope happens. The participant adoption as of September the 2nd, these are the different health centers and hospitals that have adopted this HIE to date. And go ahead. And you'll notice on that previous list that the specialty care is not there. So on our networks, whether it's managed care or commercial plan, our patients access specialty care. They access this care at usually privately run provider offices that are not connected to any EHR, certainly not the same as health centers or hospitals. Because they haven't been incentivized as health centers. They don't participate in meaningful use. These are for-profit specialty care clinics. And also the other reason is because a lot of our specialists that were open to serving populations that are low income and customarily the populations that health centers serve, the specialists have opted out of serving them. Why? Because the reimbursement for Medi-Cal has been very low, like 33% of what Medicare reimburses. So many of those specialists have opted to only serve commercial patients. In any case, they have their own practice management systems in their offices, and few of them would be able to participate in an HIE as we have described up to this point. How they do access information is if they are hospitalists and they have hospital privileges to follow their patients in the hospital then grants them a portal. And that's how they're able, these specialists from private practice offices, that's how they're able to access their patient care, and they can see what has, transpired there at the emergency room or inpatient admissions information at the hospital and discharge sheet and so forth. That's how they access it. It's not through HIE. So the champions to date have been, the directors of nursing, absolutely great. Our HIEs, that they're in charge of our HIEs measures, benchmarking care at health centers, and that's nationwide. Our CIO has been very involved, clinic managers as well, risk managers, EHR meaningful use expert. Basically the whole team has been very much involved. Now, HIE, the way it works is here at La Maestra is that for the patients that are seen at the emergency room, the message is sent to our providers through directed exchange at an inbox, and then it pops up there, and then the providers can hit the link, and the link takes them back into the HIE. And for us, this has been greatly facilitated by Next Gen Share program. It's like Next Gen is our EHR, and our EHR added this share component, and it was for free, and we piloted. We were in one of the first pilots, and it just came up this last summer, and it seems to really be helping a lot to ease into the system, and it makes it much quicker to access that information. Otherwise, we were finding that our providers were just they would just rather go through their own portals here at the clinic. Here at the clinic, seeing our patients, they would go through their portals that they had been assigned by the hospital rather than go through the HIE, because it took too long. What we did to help train the providers, of course, and the staff, constant workshops, webinars, and then on site we had extra medical assistance with that additional training, in HIEs, and they kind of help with the whole patient flow, and make sure that that Health Connect inbox was checked every day, and follow-up visits and so forth. Okay, almost done here. Let's see. The consent form was a big issue. If the patients didn't sign the consent forms at the emergency rooms, or let's say the managed care plans or the other HIE partners, the system or the policies and procedures did include a ability for the primary care provider to so-called break the glass to see the record, to see that patient record without the patient consent, because it was the attorneys and legal advisors said, it's all, as long as it's for the best of the patient and their care and their treatment, and it's part of that patient care treatment experience, then then that would be covered. And we basically receive a very small number of requests to send our patient records anymore to anybody. So except for private practitioners, like I said, that are not hooked up to any HIE software. Now, outside of our HIE, as I mentioned, like our pediatricians had been much more successful in having portals that they were assigned, especially at Children's Hospital, Children's Rabies Hospital, and that was great. It's not only that they could see the information, but they could add information there too for the specialists that were perhaps continuing monitoring the care of our primary care patients. And also some of our providers are also employed at major hospital systems, so that's much easier for us, and they wouldn't need the HIE consent. That's helped a lot. We have 3 different options for the patient consent form, and we encourage, all of our staff encourage our patients to sign this. Right now, once it's signed, the patient would then have to request to basically disenroll from this consent by filling out a separate paper. This is kind of gives you the choices. What data do we share? And each partner can decide which information could be transmitted and protected. This was a huge, took a lot of time at the beginning of this whole pilot back in 2010. And then potential for patient harm. That was another question that our providers were looking at. The whole issue of especially what some of our managed care plans were referring to as frequent flyers. These are substance abusers that were hopping from one hospital to another, and since there was no link to, or no master index of who had been receiving what controlled substance, that's kind of what would happen. And patients would end up being prescribed, a lot of controlled substances. So this definitely was one of the reasons why we encouraged, some of the more reluctant hospitals to participate. We at La Maestra adopted the stance of, we would rather share everything and have it open for the benefit of the patient care throughout the continuum of care, whether it's at specialty or at the emergency room or inpatient care, especially for our chronics. Yeah, the patients do have to formally ask to not share the information, and that's the way we deal with that, but that really hasn't happened. Let's see, delay in availability of records. For a while, the HIE was, it's supposed to be real time, but somehow there were lags in there, and so it was hard for our providers to look up to see the, the latest labs. Let's say they could see the labs, but they wouldn't be seeing the hospital face sheets for a minute, and actually it's much more than a minute to start with. Different EHR systems complicate things because then we have to build interfaces that we ended up paying for through, we meaning the health centers, ended up paying for interfacing for our lab, which is very costly, and also the pharmaceuticals. Sometimes the companies would kick in some money to be part of this building the interface, but really at the end of the day it was our responsibility. And that's something that we would try to do differently in the future. So that's the end of the presentation that we have. And any questions, I guess I'll turn it back to you, Dr. Leon.
Thank you, Zara, for your presentation, and thank you very much to Andrea. And we are going to start the Q&A session. If you have any questions, please submit it through the question box on your control panel, or use the hand raise icon, and your line will be unmuted.
If you have questions, you can type them in there.
Now, there is a question, Andrea. This question is for you. Does the Maryland Department of Health and Mental Hygiene work with community health centers to obtain health data, or do you have any plans?
Yeah, that's a great question. So we have a department and administration here at DHMH that does work with community health areas, and a lot of different projects go on. That administration is called the Health Systems and Infrastructure Administration, and I think most of their work falls under what's called our SHIP program, the State Health Improvement Process, but they have a lot of other things too that they do. So that's I don't know the specific work exactly, but we have if you want to Google the Department of Mental Health and Hygiene, you could find that information probably on the website about under HIEs, HSIA, or SHIP, SHIP.
Great. Thank you very much, Andrea. And I think this question is for you too. The question is, how do you identify areas of concern? For instance, how did you identify overdose deaths as a problem, or if there is any other areas, mental health issues, or any other chronic medical conditions?
So it's a question like how do we go about identifying hotspots, or how do we, or is the question more like how do we choose the focus of the department?
I think that
I could answer it both ways if you want.
Okay, that's fine.
Okay, so so the first way, basically, how do we identify physically these areas? You know, with our surveillance data, you know, we have, like I said, the earlier in the presentation, the hospitalization and emergency department visit data. We have birth and death data that we create, birth and death indicators and measures, and we also have prevalence data from, we have about 3 or 4 surveys that we run in the state, and so we're able to identify prevalence of certain conditions. And so using that data, they all have, you know, some types of geographic indicators in there, by at least by county, and most go to a lower granularity, like you know, zip codes or groups of zip codes. And so then we're able to look at that data geographically and assess where the hot spots are in Maryland. And then to the other sort of way you could ask the question, like how do we pick a priority area? Well, you know, we don't necessarily, I mean, we do have department goals, but overall, you know, we still have this ongoing surveillance for several different measures that we always do no matter what. Now, if we're going to go in a little bit deeper, like me in particular, if I get involved in something with a VDU work, that's typically something that our department-wide goals that we want to kind of hone in on a little bit more deeply rather than just the general surveillance. And so they determine those types of things, those types of projects, just based on those general surveillance numbers. And so we saw this huge amount of overdoses just jumping up, like I said, from 2011 to 2012. And so that was like a red flag in the data that we got to start following this closer and looking at it more in depth. And then we also have, people that do things, like I just handle the data, but there's so many people here that are tied into the interventions and working with communities. And, they were talking to the cops and other entities in the state, and the cops were seeing a huge increase in their arrests for drugs. So it's that type of thing, just based on not just the data, but what other partners are finding in the state. And then it's kind of like a red flag, and then we take a closer look.
Thank you very much, Andrea. And it seems that Zara Marcellian has some questions for you. Zara, would you like me to ask the questions, or would you like to ask the questions?
Well, whatever you prefer about that. I mean, I could just ask them quickly here.
All right, you can ask the question, Zara. I think that you have some questions for her.
Thank you so much. I was going to ask, you said that all the hospitals in Maryland are part of CRISP, but are they all on the same EHR system? In other words, are all the hospitals in Maryland, do they all belong to the same EHR system to then be able to have adopted CRISP, or how does that work?
That's a great question, and the answer to that is no. There are a wide variety of different systems, like, some are more technically advanced than others, and so, it might take, one that's not as, up to par on the technology a little bit longer, but eventually they were able to all connect to the CRISP system despite their different systems. And then the other thing I probably should have also mentioned earlier is this is all hospitals, but it doesn't include like behavioral health, strictly like psychiatric or behavioral health hospitals. So we don't have them in the system, but we have all the main hospitals and 2 freestanding emergency department units.
Thank you. What about the FQHCs in Maryland, the health centers?
So I know I mentioned the administration earlier for the previous question, the HIEs and our SHIP program. They are really tied in around the FQHCs, but I'm personally not familiar with the work exactly that they're doing. But I know that I don't know. I'd have to get the list of what they are to know if they're tied into the CRISP system.
Okay, that would be great. Maybe you and I could maybe send some emails back and forth offline. That would be very helpful for me.
Sure, absolutely. Yep.
Okay, that would be great. And then let's see. And then just one more question: does CRISP manage the exchange of patient data for the day-to-day care, whether it goes from primary to specialty to hospital, inpatient, and back? Does it do that, or is it mostly concerned with retrospective in order to then form strategies for preventative measures?
So I think, and here I'm answering for Scott, but I've had a lot of discussions with what they're doing and what they do with their data. And so it seems to me like it's set up more to be a current tool, for the real-time alerts. And this retrospective use that we're using it for is actually kind of unique, but, it's another thing that we can be doing with it. But for CRISP themselves, I think that the priority would, with the data use, would be using it like in real time for tracking the patients and alerts.
Okay, and then just one last question. in terms of funding, does the state then pay the bill then for this CRISP to be used at all the counties?
So as far as I'm aware right at this point, so CRISP isn't our only HIE, and it's the one that we've been working with in the state the most. But as far as like funding them, I'm not sure about how much. I would say for sure we don't 100% fund what they're doing. But other than that, I'm not sure if some of our funding.
Great, thank you so much.
Sure.
Thank you, Zara. And there is one question for you, Zara. Has La Maestra formulated any health promotion initiative or initiatives since its participation in the Health Information Exchange?
Health promotion around chronic disease
I'm sorry. Yes, around any activity like when I was reading your presentation, there is something, for instance, on heart diseases.
Yes, cardiovascular was the first one.
Right. Have you or has La Maestra implemented any health promotion initiatives based on the health information exchange?
Yes, we have. I mean, we already had initiatives around the different chronic diseases and so forth, but this was more on a bigger collaborative model, and we've done similar collaborations through our consortia, the Council of Community Clinics, so it would be like county-wide or counties-wide, but this HIE took it to a whole other level. So this way we were able to track those patients that we specifically wanted to identify participating in this specific chronic disease group, which was the cardiovascular patients, and then monitor how that exchange of information was actually happening. So yeah, it was fantastic.
Great, thank you very much. Once again, I would like to thank Andrea and Zara for these wonderful presentations. We need more people like you to keep us abreast on important topics like the one you just presented. For all the attendees, please visit our website. You will find information about webinars, monograph, fact sheets, training manuals, newsletters, information about our annual symposium, and information on training on technical assistance and one-on-one assistance. You can also join our mailing list where you will get HRSA updates, Medicare updates, funding opportunities, information about senior programs, other resources and services, and information about webinars. You can also follow us on social media, Twitter, and our YouTube channel. If you have any question, any training or technical assistance need, please feel free to contact each of our talented staff members, and we will be happy to help you. Once again, I would like to thank you very much for attending this webinar, and thank you to Zara and Andrea. Thank you.